resectable pancreatic cancer.
Dear Chairman, thanks very much, dear colleagues. It's a great pleasure for me to go through the data now on resectable pancreatic cancer and neoadjuvant treatment. These are my disclosures. And in resectable pancreatic cancer, chemotherapy in the adjuvant setting is still the standard. And we already seen the data, and we can double the 5-year overall survival rate from around about 9% without chemotherapy to 20%. And we may use both, as we learned, 5-FU and gemcitabine. However, we have many early relapses, and this is the problem, we have many patients who have a relapse very early on after surgery without actually having any evidence of additional disease upon surgery. And this is a challenge we have to face, even when we treat patients with adjuvant chemotherapy. And of course, it's difficult to talk about resectable pancreatic cancer because it's still a debate, or let's say it's a continuum. And I think in the next session we will talk about the continuum of resectability in pancreatic cancer, but this is up to the surgeons, of course. And Andrew Rim, who is also here in the audience, who will give a presentation later, has made a very nice publication showing that very early on, pancreatic epithelial cells, even at the pan stage, once they have a RAS mutation, already acquire the capability of actually migrating and invading. And upon acquiring additional mutations, such as in P53 or SMAD4, they also have then the capability of colonizing. So very early on in pancreatic carcinogenesis, we seem to have the capability, cells have the capability of really invading and migrating. And therefore, and this explains the data later on, we've seen from the Harvard group, and what they could show in a biostatistical model using their own pathological data is they put up a computational model, and they show that there is an exponential growth in pancreatic cancer, and many tumors, not all of them, but many have actually a high metastatic potential, and even small tumors can exhibit microscopic metastases prior to surgery. And even at a very small tumor of 2 centimeters in diameter has round about almost an 80% chance of having micrometastases. This is probably not true for all pancreatic cancers, but for a substantial proportion of the tumors. And the question is, can we tackle that? And maybe neoadjuvant treatment could improve the survival of these patients. So what are the pro-arguments for neoadjuvant treatment? And Karen already nicely pointed out some of the arguments. Pancreatic cancer is mostly a systemic disease, and 80% of patients die from metastatic disease. We could maybe treat the micrometastasis if we have efficacious treatment available, and therefore neoadjuvant treatment might confer a survival benefit. We also may be able to treat more patients in the neoadjuvant as compared to the adjuvant setting, because we sometimes lose patients in the post-operative scenario due to complications. Maybe also the pre-op treatment is better tolerated. We can actually employ better protocols as compared to post-operative setting. We will get some data now on the more intense adjuvant treatment regimens when the trials has just finished, and for gemcitabine and nab-pac, and we'll see how well this is tolerated in the adjuvant scenario. And maybe we can reduce intraoperative parenchymal tumor seeding and maybe reduce the risk of local relapse. These are the pros. And maybe also, but this is not an issue for resectable tumors, 1/3 of initially unresectable tumors become resectable upon the adjuvant treatment, but this is the scenario for the next setting. So what are the aims? We would like to increase resectability, clear resectability. We would like to target occult disease. And this is the case in some cases, not in all countries in Europe. Sometimes there is a delay between diagnosis and surgery, and this could be bridged also by a neoadjuvant intervention. And we may have a unique window, and this has to be seen, of course, from both sides. On the one hand, we could identify patients with rapid progression who can be spared ineffective surgery. On the other hand, we don't know whether surgery would be ineffective in these patients, and this is something we would need to find out. And we could study the effects of an interventional treatment on tumor biology and response. And I think this is very important because we can learn which patients actually do benefit from the neoadjuvant treatment, and we can actually differentiate it from those who don't. And we don't have to expose all the patients in future to something that doesn't work for some patients. So maybe we can actually target treatment better. And the question is, what do we have in evidence? And these are the available literature with respect to meta-analyses, but we have to bear in mind, and this can't be blamed, you can't blame the authors of these meta-analyses, but we have to blame the trials. These are actually not meta-analyses because the quality of the studies is really not up to be put into a meta-analysis, but it's the best what they could come up with. And you see there's a bit of a very heterogeneous database. Some actually have included also radiochemotherapy into their analysis, such as the Gillen analysis. Studies are prospective and retrospective, gem-based, 5FU-based. Some have used combinations. Many single-arm trials with highly selected patients, and the number of studies is quite different. The biggest analysis is certainly this by Gillen with 111 studies and 4,394 patients. However, when you see the study periods, this is all up to 2010, so this is before we had more and better chemotherapy protocols. But what are the conclusions with respect to the resectable scenario? And all of them, they have a marginal support for neoadjuvant chemotherapy in resectable patients. As CP also states, until more effective agent available, only patients with locally advanced and not with resectable disease are likely to benefit. And again, in the Gillen analysis, for initially resectable tumors, resection rates and survival are comparable with neoadjuvant versus upfront surgery, and therefore upfront surgery plus adjuvant is preferable in these patients. So can we do better than these analyses suggest? What are the data there with the conventional treatments we had available up to then? We have complete responses are very few, partial responses 10% here in Gillen, 30%, but this is also due to the fact that the radiochemotherapy was included. This is not only chemotherapy protocols, mostly stabilization of disease. Surgical outcome resections in the 80% rate are zero resections, also 80 to 90%. And survival following resection, median survival 30 to 25 months, 1 year survival up to 90%, 2 year survival sometimes only as low as 40%. So the median survival without resection, 9 months and 8.4 months. So resection, of course, is the clear curative approach in pancreatic cancer. There is no doubt about that. And the question is, can we somehow try to make it better? But these analyses, as I said, have a lot of confounders and methodological difficulties. Again, one must say this can't be blamed on the authors of the meta-analysis, but on the poor quality of the studies that were available. So what about new regimens? This is one pilot study with triple chemotherapy, FOLFIRINOX, in locally advanced, not in resectable, locally advanced tumors. What you see is, yes, you can resect 4 out of 12 could undergo a zero resection, and they actually achieved a much better survival. This is just a hypothesis generating. We don't, of course, it's a highly selected population, but it's actually quite good news. What is in other protocols? This is gemcitabine nab-paclitaxel in neoadjuvant setting in resectable or borderline resectable tumors. Unfortunately, we don't have enough studies, even small studies, that clearly differentiate the two entities. These two trials really focused on the resectable. This one had also borderline resectable included. Resection rates were also in the 80% range. The zero resections were pretty good, suggesting there is some substantial downsizing. Survival is not reported here, and 18 patients were alive at a 13 recurrence-free time of reporting. And toxicity, and this was interesting, is actually not too bad. We had grade 3/4, but we don't have any more serious toxicity that would prevent surgery in particular. This is just one slide of the study by Alvarez, which I just pointed out to you. And what I really like to focus on, there were 16 patients clearly resectable, but only 12 patients could undergo surgery because of progress of disease. So around about 25% could not make it to surgery. And we have to debate this, because this could be either good, because we prevented surgery from patients that wouldn't have been benefited. On the other hand, we don't know that. We haven't got clear evidence for that, and I think we need randomized trials to analyze that. Interestingly, another problem we'll see, only 10 out of 12 had really pancreatic ductal adenocarcinoma, so 2 were not pancreatic cancers. But we had 6 major responses in these patients, so there is a clear-cut and not actually small subset of patients who really has major benefit from this disease. And interestingly, you can monitor these patients either by CA19-9, which is actually quite interesting here, also by endoscopic ultrasound and elastography, and you can also do, if you have the resources available, PET scanning. The long-term outcome, progression-free survival 20.2 months and overall survival 30 months in the good pathological response. And you see here actually not very good data in the poor pathological response. So actually we think we need to develop these concepts in such a way that we are able to differentiate who is benefiting and who not, because these patients probably did not benefit at all from the treatment and should not be exposed at all. But we can do with the chemotherapy, we can do something to the tumor. This is just one example what these nab-pac might confer to, which is changing the collagen structure of the tumor. We don't know what this effect, how this contributes to the overall effect of the compound, but I think it's interesting because we have different ways to address the tumor biology at this moment in time using different compounds. This is just one paper which is recently published showing what could be a potential strategy, neoadjuvant treatment, 2 cycles at least, 4 cycles post-operatively, and what they could show is that in all cases they could significantly reduce tumor size, both in the resectable as well as in the borderline resectable tumors, and 2 cycles may actually already be sufficient to see an effect. What I find it's even more important, again, I have to point out, they had patients that progressed during treatment and could not be resected. On the other hand, we have a quite favorable toxicity profile. When you look at G3, G4, grade 3, grade 4 toxicity, we have virtually nothing here, which actually makes this regimen quite favorable for a neoadjuvant treatment and doesn't actually preclude surgery in any way. What in general toxicity, these again are the data from the meta-analyses. They show that toxicity doesn't seem to be a problem, doesn't seem to prevent surgery. There's no major difference in grade 3-4 between the groups. There is, of course, slightly higher grade 3-4 in the neoadjuvant regimens because they tend to be more aggressive. But when we look at the morbidity and mortality, this seems to be higher in those patients that actually had a locally advanced tumor that was initially not resected because we have more aggressive regimens, including radiotherapy, and this seems to really impact on morbidity and mortality. In the clearly resectable patients with less aggressive strategies, there was no difference at all. This is one trial we're just running in Germany, a multi-center trial. This actually follows does exactly the same as the Spanish group do. We have 2 cycles in front and 4 cycles after surgery as compared to 6 cycles of gem/nab-paclitaxel in the adjuvant setting. We do randomize these patients, although the trial is not big enough with 166 patients to really have a direct comparison, but we need the randomization not to get a bias between the 2 groups. Having those patients who would like to have surgery immediately in one arm and the other one to say, yeah, do it in the other arm, so we need to randomize these patients. There's a lot of trials, and I don't want to go into detail now with examining exactly this concept. Neoadjuvant treatment with gemcitabine, nab-paclitaxel. Of course, the same is true for the triple chemotherapy, FOLFIRINOX, and sometimes, I think there's something also we could discuss, what should be the outcome. And you see there's different things, resection rate, for example, PCR, progression-free survival, or overall survival, or even feasibility. So in a concept that is nowadays already used in some centers routinely, we're not even clear what we want to achieve. And personally for me, at least progression-free survival or overall survival is a sensible outcome in a resectable scenario. We have to improve overall survival, otherwise the concept is not really valid, at least as far as I'm concerned, but I'm happy to discuss that with you. But feasibility, of course you have to check that in very early on, but nowadays we know how to use that protocol. So we have to think about how do we move the field forward and not just have a proof of concept that this might work. And there are also direct comparisons, which I find particularly interesting, and this is our American colleagues in the SWOG do this, and they do run a head-to-head comparison. What could be the winner, nab-paclitaxel plus gemcitabine as compared to FOLFIRINOX? I think this is a very interesting trial to move the field forward, also with respect who might benefit from which strategy, and I hope they have enough resources available to really do the molecular biology and find profiles that either are in favor of one or the other protocol. This is, I've taken from a review from Jean-Luc von Letem's group, and what they propose here is a very nice setup for patients in either resectable, borderline resectable, or locally advanced stage. I think we are not quite there yet to recommend neoadjuvant chemotherapy and chemoradiation in the resectable stage. I think this is still a matter of trials, not a matter of routine. And we can still, of course, in the next talks, we will have the borderline and locally advanced scenario. To conclude, I think adjuvant treatment of resectable PDAC is still standard because of the poor quality of the studies available. The neoadjuvant treatment with novel chemotherapy combinations could substantially improve outcomes, at least in subgroups of patients. Toxicity doesn't seem to be a major problem. Our zero resection rate does increase. There is an impact on overall survival expected, but it's not yet clear. We have to prove that in the trials. So, and I would like to point out some questions I have to the trials. What should we get out? What information should we get out? We need to know the duration of the preoperative chemotherapy, in particular in resectable pancreatic cancer. Is the longer the better in case of response? So should we carry on treating patients who are really well responding to the neoadjuvant treatment, or when do we start operating on them? And do we need the adjuvant part of the chemotherapy? Shall we do everything up front? And what is the benefit? How do we identify those who benefit and those who don't? I think this is now a real challenge, and we should put a lot of emphasis on that. And the other question is, would the early progressors have benefited from surgery? So I really think we do need randomized prospective trial. We have to incorporate early evaluation of treatment effects and responder, non-responder, and we may challenge the novel imaging modalities such as diffusion-weight MRI, PET-CT. And we have to include molecular staging and characterization of pre-therapeutic tissue by USFNA or even by liquid biopsies for biomarker analysis and to guide the subsequent treatment. And with that, I thank you very much for your attention.